Then 9/11/2001 happened, and I was there for that.
Oh, wow.
So I remember I was a surgical intern at the time, and I was looking out of the window at the hospital I was at, and I saw the first plane come and hit Tower Number 1. I
No
witnessed
way.
it.
Wow.
So we got the call over the intercom, like all physicians and surgeons that report to the ER, to prepare for the onslaught of patients.
Wow. Welcome, everybody. Welcome to the D4A Personal Injury Show. I'm your host today, Jean-Paul. Unfortunately, today we did not have Nicole with us, and I know we all miss her very dearly. But today we do have a special guest on the show, a pain management doctor from Marina Del Rey and Manhattan Beach. We have Remedy Pain Solutions. Doctor is Akash Bajaj.
Akash Bajaj.
Akash
You got it.
Bajaj.
Yes.
I like that name. It's
Thank
kind of
you.
like my name, Jean-Paul. Everybody always says Jean-Paul.
Right.
And it's like, wow. So, doctor, thank you so much first for coming here. You are a board-certified pain management doctor, and you also have regenerative medicine and I believe something else in your practice. What are they?
Yeah, so I'm a triple board certified physician. My primary specialty is anesthesiology, which I finished at UCLA a long time ago. And then after that, I did a fellowship at UCSF, UC San Francisco, which at the time was the #1 program in the country for interventional pain management.
Wow.
Then I practice interventional pain management. But during the pandemic, I also decided to broaden my practice, and I got a third board certification by the
Nice.
American Board of Anti-Aging and Regenerative Medicine. So I do some anti-aging medicine as well to kind of complement the field.
Great. Sign me up. I don't think anyone wants to age, right?
That's right.
I guess tell us a little bit about how you became a pain management, what made you decide. I know a lot of people say they've had a family member who, was in a tragedy or was sick or, there's so many different things that we've heard on the show. So tell me, what made you want to become a pain management?
Yeah, I mean, I think that story starts way back with kind of my childhood, right? And growing up, believe it or not, I was a car mechanic. And I was
Wow.
very happy being a car mechanic. And my plan was ultimately just to be a car mechanic and kind of figure that out. My father was kind of in that same line of work, and it worked out for us. And frankly, it was all I knew. But, at one point, I wasn't able to even get into a proper college because I was just goofing off during my early years. But at some point, when I got into college, after finally turning my life around, after, just kind of changing my way of life, changing my mindset, and kind of changing my habits, I decided to really accept the fact that I could do whatever I really wanted to do. And I kind of got over those negative mindsets and negative beliefs, thinking to myself, what do you really want to do? Like, if you could really pursue your biggest dream, what would that be? And for me, that was being a doctor, getting into medicine, right?
Yeah.
Which basically was like landing on the moon, given
Yeah.
where I came from.
Yeah, that's a big difference.
Yeah, totally different, man. So literally overnight, I kind of made a 180. I mean, I went from being this guy that wasn't really contributing much to society, contributing much to myself, to my family, to really anybody around me, just getting into trouble all the time. I got expelled from schools when I was younger, to really just changing my life. I basically deleted my entire friend network at the time. We didn't have the internet, otherwise I would have deleted all my social media.
Yeah.
And just kind of changed my ways, became a total nerd, and eventually got my way into medical school. It's a crazy story, though. I applied to 31 medical schools.
Wow.
I had to call 4 of them to basically influence them and suggest to them that it was worth interviewing me beyond what they may see on paper. So I ended up getting 4 interviews after those conversations. And you know how many med schools I got into? 0.
Oh, boy.
0, right? So
Oh,
I was like,
boy.
okay, well, Akash, maybe you're shooting a little bit too high here. Maybe you're not quite ready for the big leagues. So I decided to go to med school kind of offshore, out of the country.
Yeah.
And I was literally in a hotel room getting prepared. I had got accepted to the offshore med school, and we were getting prepared to like do the orientation and all that stuff. And I got a call in the hotel room. And this is before cell phones or anything like that. So picked up the phone, and it was one of the med schools that I had applied to. Said, hey, Akash, we got a spot available, and if you want it, you got to move to New York in 1 week. And at the time I lived on the West Coast. I said, sure, let's do it. So I accepted the spot. I got out, checked out of that hotel as quickly as I could, and went back home, packed my
Nice.
stuff, and moved into to New York and started medical school.
That's huge.
It's
Yeah.
crazy, man. Yeah, it's a crazy story.
Yeah, well, that shows you the dedication. You were so
Yeah.
in that mindset.
Yeah, I mean, that mindset really allowed me to kind of overcome a lot of my own personal obstacles, and still continues to let me do so today.
Great.
But I think getting into med school was a whole different beast. You think
Yeah.
you're kind of top of your class, top of your game, so you can get into med school. But now you're dealing like in the professional leagues, like, you know, you were kind of Pop Warner, and now you're in the NFL.
Yeah, big time.
And it's a whole different ball game.
For sure. And down the line, was there any, mentors or anybody that you thought that would, or not thought, but somebody that influenced you to just, like what you said, you picked up your stuff and just decided to be, the top of the top?
That's a great question, man. And I'll tell you, honestly, it was my parents. I mean, my parents are first generation Indian immigrants to the U.S., and they did exactly that. My mom and dad met about a week later. They'd moved from India in their early 20s to the U.S. Originally to Canada, and then eventually to the U.S. In Canada, I was born, and then my younger brother was born. And then in the U.S., no education, no formal training. My dad's like, let's just figure it out. So he went from being like a New York City taxi cab driver to a car salesman to ultimately owning his own chain of automotive shops in San Diego, which he ended up selling all those and retiring in his mid-50s.
Amazing.
And after that, I'm like, listen, if I come from that kind of a lineage, and they can do that, that is in me. And I have to kind of uphold that and continue that kind of line. Not just for myself, but also for if and when I had children at the time.
Yeah.
So thinking about that and understanding, look, I'm in America now, I'm in medical school now, I'm healthy, I'm smart, there's really no reason why I can't do pretty much anything I want to do in medicine.
Yeah.
Initially, I was like, okay, well, what do you want to do? Well, I was watching a lot of TV, and plastic surgery seemed pretty cool. Watching that show Nip Tuck a lot, I'm like, that sounds like a lifestyle.
Nip Tuck. I watched all the seasons.
Right? That I'd love to have. But eventually, during medical school, I realized, like, that wasn't the path for me. And the path for me was really more pain management.
Got it.
Now, how did I end up in pain management? Well, I was doing a rotation in New York City in the oncology floor. And there was a patient. His name was Junior, actually. I remember this guy vividly. He was kind of like one of these high-end models. Turned, he's a patient now, but he was one of these high-end models for like Tom Ford or something like that. Very, very high on his game. But this is during the AIDS epidemic. And this hospital was a huge epicenter in New York City for those patients. So he had HIV and eventually AIDS, and he was just dwindling down, unfortunately. Had a bunch of oncological issues, a bunch of little cancers running through his body.
Oh boy.
So this guy went from being like top of his game, just like the ultimate, to being like patient number X, right? Very few visitors, everybody kind of scatters sometimes because they don't want to deal with that kind of a tragedy daily. Right. It's a gentle reminder of our own mortality.
Yeah.
But I ended up treating Junior. We ended up kind of developing a really good friendship. And even after my rotation was over, I just kept checking in on him every single day, right? And he would ask for me and stuff. And it was just a beautiful thing.
That's awesome.
So I thought I was going to go into oncology after that because of Junior. But the last I'd say maybe 2 to 3 weeks of Junior's life, I noticed that his pain was totally uncontrolled, totally ignored, frankly, by doctors, nurses. And I realized nobody knew how to treat it. Nobody knew what they were doing.
Right.
So kind of scared me, like, wow, nobody knows how to treat this kind of pain, and all they were doing is throwing opioids at him. Just give him more morphine, give him more opioids, and just, shut him up so we don't have to deal with him.
Right.
And I just realized, like, this is a field where there's so much opportunity to do so much, and at the time it was a very young field. I wanted to be one of the forefathers in the field and really kind of help grow that field and make sure nobody else got treated like Junior ever again. At least not under my watch.
Yeah.
So I switched to pain management, which at the time you could only enter by going into anesthesia.
Wow.
So that's how I originally did anesthesia. But I was there and I'd matched at a anesthesia program in New York City. But and I was going to stay in New York City forever. I loved it. My family was all on the West Coast, but I was a New York City guy at the time.
Yeah.
Totally had taken it in. But then 9/11/2001 happened, and I was there for that.
Oh, wow.
So I remember I was a surgical intern at the time, and I was looking out of the window at the hospital I was at, and I saw the first plane come and hit Tower Number 1. I witnessed it.
Wow.
So we got the call over the intercom, like all physicians and surgeons that report to the ER to prepare for the onslaught of patients.
Wow.
And we saw like 3 patients. Nobody came in. I ran to the middle of the street, which was, I think, 11th Ave at the time, and we looked down towards the World Trade Center. And one of my nurse friends was with me, and she was like, I think this is war. And I'm like, no, don't be crazy. This is not war. That was just a air traffic control issue or whatever.
Yeah.
And literally as I'm saying that, plane number 2 comes around and hits Tower Number 2. And I'm like, yep, I think you're right. Wow. So All chaos ensued, as you can imagine. Because I had my green scrubs on, ambulances were flying down. I jumped on the back of one with my buddy, who's now an ophthalmologist in Northern California. We went down to Ground Zero, and we were just looking for survivors. So we were literally the first of the first responders, if you can imagine.
Yeah, wow.
And it was crazy because nobody was around. If you were standing this far away from me, I couldn't see you.
Wow.
Because there was just so much debris in the air.
Right.
And more importantly, I couldn't hear anything. It was dead silence.
Man.
Because nobody was around.
Yeah.
So imagine that, right? So we ended up coming back to the hospital. I saw maybe about 20 to 30 patients at the time. And it was wild because being an anesthesia somebody going into anesthesia at the time, they basically said, okay, we're setting up this MASH unit, Mobile Ambulatory Surgical Hospital. They set it up at a place called Chelsea Piers, which was a big gym in New York City. Mm-hmm. And they're like, look, you're going into anesthesia. You got to man these 2 operating room tables, which is a cafeteria table, and do anesthesia.
Yeah.
I'm like, I really don't know how to do anesthesia. That's why I'm getting trained in it.
Yeah.
And nobody came in. So, and the few patients that did come in were either burn victims or there were panic attacks or whatever. But after all that, I just realized, like, look, I need to enter a field that makes a massive impact. And that's kind of also why I decided to go into pain management. After that, I decided to transfer from New York City back to California because I realized, look, like my family was in California. Life is super short. You never know what's going to happen.
Right.
And after that happened with all the debris in the air and everything that lingered for months and months, I personally had some medical issues. I had like dermatological issues. There were about 12 of us in all of New York City that had that.
Wow.
And nobody could figure out what it was. I saw like 100 dermatologists. Nobody could figure it out. But I noticed that every time I went to California to visit family, it just went away. It would just literally stop instantly. So I decided, family's up back on the West Coast. This issue I'm dealing with is on the West, so I'm going to transfer back. So I transferred to UCLA for anesthesia.
Wow.
And then continued that journey. And then I made it to UCSF for pain because at the time, like I said, it was #1 in the country, and just completed my training there.
Man, that's amazing. That's a great story to tell, man.
Yeah, thanks, man.
I can imagine you writing a book about it because I'm sure you'll. Yeah, I'm serious. I mean, nowadays everybody. I mean, not to go off subject, but it's a lot of people downplay the whole, sharing your story on how you got to where you're at. And it really does help because it shows that there's, other people out there that go through the same things and then eventually come up top because they push themselves and they just do things. They just get it done, and it's just like you said, it's that mindset. And it takes a lot of courage to move away from your family and, move to a whole new place in New York. New York is huge.
Yeah.
And so, that's in itself, it's very motivating. I have some interesting questions for you. I'm sure you don't get asked a lot, but here at the PI show, the Personal Injury Show, this is where we're talking mainly about like car accidents and stuff like that. So, what have you seen since you've been here in LA? What type of car accidents? What are some of the tragedies that happen? Are there things that we can do in order to not get spine injuries and whiplashes and stuff like that? Is there a certain way we can hold on to the, steering wheel or wearing a seatbelt, or is all that just out of the window and it doesn't exist? And anyways, you can answer.
I mean, I think in a perfect world, it would be great to be able to prepare for all these things that we don't necessarily know is coming down the pike, right? Just
That's
like
true.
in life, though, we can only do so much given the information we have at any given moment. And that includes if you're driving to work one day, who knows if you're leaning over to grab that Starbucks and that's the moment you get hit.
Right.
There's not a lot you could have done to maybe avoid that.
That's true.
However, that being said, as a previous motorcycle driver as well, defensive driving is paramount importance.
Yeah.
And I think the pro and the con and the beauty and maybe the not so beautiful thing about Los Angeles is it is a big car culture, right? One of the reasons I love it so much. So if you're a car guy like I am, I mean, you love LA. It has every kind of amazing car culture thing you would want.
Yep.
But because there's so many cars, a lot of those cars are kind of impacting each other.
Yeah.
In my practice, like typically what I see a lot of neck issues and a lot of low back issues. Specifically a lot of whiplash, which can be mostly musculoskeletal with some spinal-based pathology as well. But also, if the accident's bad enough, you can have a disc in the neck or the low back actually herniate or push out from the vertebral column. So that's almost like the disc, which is a jelly donut, starting to become pushed out, and some of that jelly within the donut can squeeze out.
Yeah.
And then when that happens, you can have a host of different types of symptoms.
Right.
because right next to those discs and the vertebral column are nerve roots in your spinal cord, right?
Yeah.
So anything impacts that or even begins to crowd it, like what I tell my patients is spinal nerves are very claustrophobic. They don't even want you to get near them, much less touch them, right?
Right.
And so when that begins to happen by a disc or maybe an arthritic joint that's been kicked off by a car accident, for example, then those nerves can start to shoot off inflammatory mediators. And that's when patients begin to feel like numbness, pain, pins and needles, tingling, weakness, maybe not right when the car accident happens, but a week or sometimes 2 weeks or even a month later because the endorphins have now decreased.
Right.
Right. So those are the biggest things that I see.
Got it. And what happens if those things go untreated?
Oh my gosh. So to have untreated issues like that, you can have a host of different problems, right? So now you have a nerve that's inflamed, and if that isn't treated and it crosses either the 3 or 6 month landmark, which is the definition of chronic pain, that becomes incredibly difficult to treat, much more difficult to treat than it was if you treated it right away. And ultimately, treating it at that point can be a combination of medications, which is, in my opinion, not the most optimal treatment whatsoever. Hopefully, injection therapy, if you catch it early enough and you have enough of an issue where you can treat it specifically, or even surgical intervention. Those are really your options at that point, as well as physical therapy and chiropractic care, of course.
We just had a pharmacist here not too long ago, and we were talking about the whole opioid pandemic or epidemic, and fentanyl and all this stuff that's going on. How does that work? Like, does somebody who has chronic pain, is that the type of some of the medication that they'll need, or they'll need like anti-inflammatories, or I mean, can you treat that type of injury, maybe not chronic pain, but just that type of injury with anti-inflammatories versus opioids?
I mean, so if you look at the research, right, you look at so there's two factors at play here. One is what the medical associations almost tell us that we have to do. Like at one point, pain was the 6th vital sign, and if you didn't treat it as a doctor, you could get in trouble because you're leaving a patient in pain. So reactively, what do most physicians do? Oh my gosh, I got to treat everybody with opioids or I'm going to get in trouble. Right? And that pendulum swang the other way. So now if you treat too much, you get in trouble. So now everything's changing, right? But yeah, the fact of the matter is, if you take all that out of the equation, you just look at the clinical data, just the science, most of the time anti-inflammatories are more than enough, as well as some things like neuropathic agents, certain medications called gabapentin or Neurontin or Lyrica, which is also called pregabalin. These are calcium channel blockers, and they specifically focus on the nerve output. Not addictive, there's no dependence, no addiction, and no tolerance. So those are great choices in conjunction with anti-inflammatories. But ideally, using just anti-inflammatories most of the time, combined with physical therapy or chiropractic care and maybe injection therapy, should be sufficient.
Got it. Yeah, I always hear the name Celebrex. I don't know if that's something, is that like an anti-inflammatory?
Yeah, so Celebrex is what we call a selective COX-2 inhibitor, which basically is a fancy way of saying it's an anti-inflammatory that only focuses on certain receptors to induce the anti-inflammatory effect, but minimize or mitigate any sort of stomach issues or heart issues. So it's a great medication. It is an anti-inflammatory, so it's like ibuprofen, meloxicam, Aleve. These all fall in that anti-inflammatory class versus something like Tylenol, which is a totally different type of medication.
Right.
The beauty of the anti-inflammatories versus something like Tylenol is they work centrally in your central nervous system as well as throughout your body. So this is why they work great for things like arthritis in the knee, in the back, whatever the case may be, as well as overall just general anti-inflammatory benefit.
Yeah, man, you just reminded me of I was probably when I was 18, I like somehow I was riding my bike, I hurt myself, and I went to a doctor and they prescribed me, I think we were called Somas. Oh my God, it knocked me out. Like I would never take that medication again because it was so bad. Like I felt just horrible. Like after taking it 5-10 minutes later, it just felt like I was in a blackout.
Yeah, so
and I think I did actually. I passed out.
You probably did.
Yeah.
So was bad news bears. So was one of these like muscle relaxants, quote unquote, but it's highly addictive. Highly addictive.
Yeah.
So patients have gotten dependent on it. There's a tolerance that builds up.
Right.
So you need more and more of it to get the same effect, and it's highly addictive.
And so, I guess, what else can you tell us? I mean, besides like a spine injury that you from a car accident, what are other alternatives that are non-invasive that you can treat your patients with?
Yeah.
You know?
I mean, so I'm the non-surgical guy, right? And so I really believe there is a time and a place for surgery, no question at all. But most of the time, if you can get away without surgery, you're in a much better place, right?
Yeah.
So really kind of a combination of anti-inflammatories, totally safe, no real downside whatsoever, incredibly effective. Physical therapy and chiropractic care, same thing, incredibly effective. Great adjunct to continue throughout a patient's care for sure, because that can be very dynamic and modified as the patient improves. And then injection therapies, right? But in respect to injection therapies, there's really a couple different types of things that you can inject. You can inject, we've all heard of steroid injections or cortisone injections, right? But there's also this entire budding field of regenerative medicine, which includes things like PRP, platelet-rich plasma, as well as stem cell injections, right? And that's what I like to focus on, because the beauty of something like PRP is it's more definitive and it's more natural. So PRP, platelet-rich plasma, really works in two ways. Once you inject that to the affected area, and that can be muscular, that could be an epidural, that could be in an arthritic facet joint or a sacroiliac joint, for example, it does two things. Number one, it takes a collection of platelets and suddenly places it in one area of your body.
Yeah.
And so those platelets release growth factors and growth proteins, which help heal the underlying issue more definitively than something like cortisone, which is like a Band-Aid therapy.
Got it.
Yeah, but number two, it tricks your body into thinking there's a new injury. Because all of a sudden your body now sees a collection of platelets in one area, so it thinks there's some new acute injury, and it activates your body's own immune system response. This is why sometimes after you get a PRP injection, a patient may feel kind of like they're like getting sick or kind of weak or fever or malaise for a day or two afterwards. This is why. So PRP really has a twofold effect, none of the negative effects of something like cortisone, and no preservatives are needed because the PRP is extracted from the blood and spun down and separated and injected in the same visit. And there's no chance of rejection because it's your own blood.
Wow, that's amazing. And what's the success rate on it?
Depends on the pathology, and it depends on the patient, right? So an 86-year-old patient who has a cigarette in one hand and a bottle of Jack Daniels in the other clearly doesn't take care of themselves, right? Even though it sounds like a good time, they're not taking care of themselves.
Absolutely not.
So their platelets are probably going to be a little buzzed as well. You don't want to use those, right?
Yeah.
But somebody who's like, you know, in their mid-30s, mid-40s or whatever, and take good care of themselves, those platelets are also going to be in optimal condition. So those are the patients that are going to respond well, but the pathology also has to make sense. If it's somebody with like, you know, 5 or 6 disc herniations and a bunch of arthritis, it's not the right patient. But if there's a pinpoint area where there's like maybe one disc bulge causing a nerve root compromise, or maybe 1 to 2 facet joints or sacroiliac joint that's just massively inflamed from a traumatic episode like a car accident, that's a great candidate.
Wow. And do you use those for like your hands as well, like your thumbs and just anywhere in the body, wherever there's...
Yeah, you can. So, I mean, most of the research has been done on knees, the Achilles tendon, and elbows. And generally speaking, the smaller, more encapsulated the joint is, the better a patient does. And what encapsulated basically means is there's like literally a capsule around the joint. So if you enter that capsule and inject the PRP, it stays where it needs to stay. A little bit more challenging with something like a shoulder or a hip because they're larger, kind of more open joints. So you need a lot more volume, but a smaller joint tends to respond well.
And then after you do like a PRP or stem cell, how long does it take to actually but for your body to heal? Like, what is the average? I know each patient is different, but
yeah, you know, typically what we recommend, depending on the pathology, is a series of about 3, typically 1 to 3 done in about 1 to 2 week intervals. Each one adds upon the previous. And then after you're done with the series, you're looking at least 4 to 6 weeks before maximal benefit is really achieved.
And do you recommend that patients sleep a lot?
I mean, rest is always good, but it depends on what you're injecting. Like if you're injecting a knee, for example, then I recommend minimal flexion and extension of the knee. Yeah. Because if they're doing that, they're basically pumping the PRP out of the joint.
Oh, wow.
Right? So, but if it's in the back, same thing, just kind of chill on that area. Yeah. But they just need to really chill, honestly, for 24 to 48 hours.
Yeah. Yeah, I have a family member who's got really bad arthritis on their lower back.
Sure.
So they did a whole bunch of stuff. They did stem cells, and that seemed to have lowered the inflammation, but it's still, still very painful. And at times you see them just having a hard time, during the day, like whether it's standing up or sitting down or getting out of a chair. I mean, and you could tell, and I can't imagine somebody living their life with that type of pain. Like it really changes your life. In so many different ways, you know.
Yeah. But the problem with that, JP, is it's like everything in life, right? They're slow. It's not like it happens overnight and all of a sudden a patient is immobile. It's a slow decline of your activities of daily living and your quality of life.
Right.
And next thing you know, you're immobile, where a year ago you were not, but you haven't even noticed it.
Right.
You know,
slowly, gradually, right?
It's like a frog in a kind of a pan of water. If you slowly turn up the heat, the frog doesn't jump out. They don't even notice it. And next thing you know, that frog is boiling, literally.
Right.
It's the same thing here, right? So that's why it's important for us as caregivers, as family members, as witnesses to these things happening, to tell that person, hey, Mr. Smith, like I noticed you're not getting up the way you used to get up. Like, what's going on? Let's take a look at your back, you know, or hey, you know, cousin, I've noticed since you've had that car accident, you haven't been able to really like play soccer with the kids like you used to, or you seem a little depressed. Like, what's going on? And you're also not moving, because there's that psychological component too, right? If I'm somebody who used to be like super active and work out all the time, and now all of a sudden I can't,
right?
You know, but I'm a guy, so I'm not allowed to talk about it. So I'm just going to hold it all inside.
Right.
Next thing you know, it's going to manifest in a way that's going to affect things psychologically as well as physically.
Yeah.
So that's our job, right? As observers, to take care of those around us.
All right. So just to go back a little bit more into the whole, I guess, arthritis thing. What are some of the things that you guys do exactly for arthritis? How do you treat a patient that has arthritis?
Yeah, I mean, so arthritis specifically
of the spine,
in
right?
The spine, right, can be related to something called facet arthropathy.
Okay.
So the term facet basically refers to the joints in the spine. They're bilateral, so there's one on either side, right and left, and they typically are one-way joints. So if you hyperextend or lean back, you kind of compress down on that joint, and if you lean forward, you typically open that joint up. That joint can become arthritic with either degeneration, genetics, or trauma. So trauma, like a car accident, for example, can exacerbate and activate an inflammatory and degenerative process in those joints, kind of accelerating the arthritic process. When they become arthritic, immediately in front of those joints is the spinal cord and the nerve roots. So they can cause not just back pain, but sometimes sciatica, or in the neck, like shooting arm pain, as well as neck pain. There's lots of ways to treat that, but something we've had a lot of success with is radiofrequency ablation, or RFA. Now, basically what that is finding the nerve that goes to the facet joint. So this is not the spinal nerve. This is strictly a sensory nerve for the arthritic joint. And we block that nerve, just inject that nerve twice on 2 separate occasions, about 2 to 4 weeks apart from each other, with just a local anesthetic. And that local anesthetic will anesthetize that joint pretty much right away, but it won't last very long.
Right.
But it'll be dramatic. Like, the patient will notice anywhere from a 50 to an 80% improvement in their pain for about 2 to 5 hours, just depending on the medication used. But then the pain comes back.
Right.
The reason we do it twice is because if you only do it once, there's a 30% false positive rate, which is very high. But if you get a successful result on 2 separate occasions, then that's justification to move forward with a radiofrequency ablation. And all that is now is going back to the nerve we've now blocked twice, and then taking a heat probe, putting it through the needle, contacting the nerve, and just burning it off with radiofrequency waves, just creating a little lesion right around that at about 80 degrees Celsius, which is almost 200 degrees Fahrenheit, for about 60 to 90 seconds. And that basically just denervates the joint. But very much like a plant, if you stop watering a plant, it begins to wither. Same thing here, and it can take easily a month for that to occur.
That's amazing.
Yeah.
Yeah.
I was just going to say it can last for 6 months to 2 years at a time when that happens. And the beauty of this whole process, you've used no steroid.
Right.
Which is amazing.
That is amazing.
Yeah.
And so during that 2 years, what do people normally do? Like, what do you suggest your patients do? Like physical therapy? There's so many different things out there. Like, does acupuncture in any way play a role in it, or
so once you denervate those joints, right? What we don't want our patients to do is just go back to living their maybe sedentary lifestyle or unhealthy ways because they feel better, right? So core strength training is everything.
Yeah.
If they can get their core nice and strong, their core can act as a reinforcing cage around the spinal canal to just keep things where they need to be. So just really kind of a lifestyle change at that point to really mitigate
big
this.
time.
Yeah.
Big time. All right, doctor. So tell me, please, what are some vitamins people can take in order to, or lifestyle? What can people do in order to overcome those pain
Yeah, I mean, sometimes when somebody gets in an accident and they can't get in to see a provider right away, like a doctor, for example, there are certain things they can do by themselves that are super safe that can mitigate much of what's going on. So, for example, magnesium, great choice, right? You can get magnesium at pretty much any health food store these days or Amazon overnight. But magnesium is a very powerful muscle relaxant, and it's a very powerful anti-anxiety medication as well, believe it or not, and really helps with sleep. So these are the three areas where after a big car accident, you're probably going to have a muscle spasm. You're probably going to feel a little bit anxious after what just happened, and you're not going to sleep well. Something like magnesium is a great adjunct to really get all of these under control and super safe. Not just that, most of us today running around in society are low in magnesium anyway. So it's just going to help you out in that area, and you can't overdose on it. You can't get yourself in trouble with it.
Yeah.
I typically recommend magnesium glycinate. There's many different forms, but glycinate is the most easily absorbed and the quickest to get into your body.
Got it.
Ice is fantastic. Probably the oldest known anti-inflammatory around.
Yeah.
Great anti-inflammatory versus heat, which is great for muscle spasms, but not great for anti-inflammatory effects. So really icing the area, whatever may be hurting, it never hurts. It's a great idea.
Wow, no, that's great. Did you guys write that down?
And then, there are things like turmeric. You can get turmeric, again, at the health food store. Lots of very well-known anti-inflammatory properties, or just eat a bunch of Indian food. I'll get you turmeric as well.
Yeah.
But that definitely doesn't hurt either.
Yeah. Okay.
Yeah.
Well, that's it. We know what to get then.
Yeah.
What are the patient success stories that you want to share with us?
Yeah, listen, I mean, we've been very fortunate to have a lot of success stories, and I think it's because we really try to get these patients in as quickly as possible. We understand how important it is. We've all been through major kind of tragedies in our lives, and for lots of our clients, this car accident is one of their biggest tragedies, right? So the quicker you can treat that patient physically and physiologically will also help them just collectively as a human being, even psychologically, right?
Of course.
So getting that patient in very quickly is very important. In our clinics, we get them in within 24 to 48 hours. That allows us to really get the imaging if we need it, get the treatment plan on board, start treating this patient right away. Because of that, we've had patients with massive disc herniations ready for surgery, and we've been able to mitigate their symptoms, allow them to hold off or postpone things like surgery, and really help themselves get better with a combination of our regenerative therapies like PRP or even stem cell, maybe other types of therapies like radiofrequency ablations, of course basic things like epidurals as well, and physical therapy to get their core nice and strong. So that general theme, as long as we can see that patient quickly, or anybody can see that patient quickly and begin treatment quickly, they're going to do much, much better.
Well, that's wonderful. Well, thank you so much for coming today. I really appreciate you being here. Yeah.
Thank you.
And do you want to tell the camera what your website is?
Yeah, sure. You guys can find me at thinkrps.com. Remedy Pain Solutions, or on Instagram, Akash Bajaj MD, all one word. If you ever have questions, you can message me directly on Instagram. You'll be talking specifically to me and me only, and I will get back to you right away. So follow me on Instagram for sure, Akash Bajaj MD.
It's like having a doctor's personal cell phone number. Well, thank you guys all for watching today. I hope you guys enjoyed this. Make sure you like, share, and subscribe, and make sure you check out the doctor's website and his, I believe, social media links. Till next time, Jean-Paul signing out. Peace.